appear on. So the first poll question is, do you currently have a loved one living in a nursing home? And you can select yes or no. We'll leave this open for about 15 seconds or so. All right. So do you currently have a loved one living in a nursing home? We had 10% of our 10% of our panelists today say yes, and the other 90% said no. Our second question, if you have visited a nursing home, what has been your experience in the quality of care? It was great care and I felt comfortable leaving my loved one there. It was okay, but I wouldn't want to stay there myself. It was awful and I worried about leaving my loved one there, or none of the above. Few more seconds, get those votes in. All right. So we had about 53% say it was okay, but I wouldn't want to stay there myself. Next 21%, it was awful and I worried about leaving my loved ones. And about 11% that said it was great and I felt comfortable leaving my loved ones. And then the last question we have is, do you think staffing needs to be increased in nursing homes? You have yes, no, or I have no idea. Again, do you think staffing needs to be increased in nursing homes? Few more seconds. All righty. So we had 90% say yes and 10% said I have no idea. Thanks for participating in our polls this morning. So this morning you'll hear from Natalie Snyder. She's an AARP's Virginia State Advocacy Director with an overview of our advocacy during the 2022 General Assembly session. After that, we'll be joined by a very special guest, Delegate Vivian Watts. Delegate Vivian Watts and her husband Dave, of over 50 years, raised their family in Northern Virginia. In 2017, this trailblazer became the longest serving woman in the House, taking her seat when only 21 women had served before. Her landmark work to change the state transportation funding formula led her to be tapped for security of transportation and public safety. Vivian returned to the House of Delegates in 1996, continuing to embrace the challenges of complex issues in criminal justice and mental health on the House Courts Committee and equitable tax reform and essential funding for public education as the ranking member of the House Finance Committee. Since 2002, Delegate Watts has tenaciously worked to establish nursing home staffing standards and related healthcare reform. AARP Virginia is honored to work with Delegate Watts during this last General Assembly session on legislation to establish staffing standards in Virginia's nursing homes, and look forward to continuing our relationship. We will have time for questions and answers, so we encourage you to write your questions in the Q&A box or the chat box. Both should be located at the bottom of your screen. As I mentioned earlier, we're going to start with an overview of AARP's Virginia's advocacy work during the 2022 General Assembly session. So I'll turn it over to Natalie Snyder now. Thank you.
Thanks, Rebecca, and thank you, Delegate Watts, for joining us. We're really excited to have you here with us today. As Rebecca said, I'm Natalie Snyder. I am AARP Virginia's State Advocacy Director, so I lead our advocacy efforts during the General Assembly with our volunteers and other staff members. And so today I'm just going to give you a brief overview. So each year, AARP Virginia volunteers and staff advocate for various issues during the General Assembly session. Typically, our state advocacy volunteers travel here to Richmond during session to visit with legislators regarding our priority issues, provide testimony in committee hearings, and observe legislative floor sessions. The past 2 years obviously have been a bit different, with volunteers only able to participate virtually, but our advocacy efforts have remained strong. In the 2022 session, we had 2 main priorities: lowering the price of prescription drugs and making nursing homes safer for residents and staff. We also advocated for other issues such as the establishment of a tax credit for family caregivers and expanded scope of practice for nurse practitioners, among others. And today I'll speak a bit about each of these issues. As Rebecca said, we'll take questions at the end, so you can go ahead and enter those either in the chat box or in the Q&A box, which is located at the bottom of your screen as you think of them, and then we'll go over those at the end. So first up is prescription drug pricing. Of course, it's no secret that prescription drug prices are out of control in the United States. We pay the highest prices of any industrial nation in the world, 3 times the price of other countries in most cases. And here in Virginia, the average overall cost of prescription drug treatment increased 26.3% between 2015 and 2019, while the annual income for Virginians only increased by 16.7%. The defense of drug pricing is generally that most of this money is needed for research and development, but pharma has spent more on stock buybacks and dividends between 2008 and 2018 than they did for R&D. And while many Virginians are struggling to pay for their medications, pharma is spending billions of dollars on advertising and lobbying, over $161 million for lobbying and nearly $6.8 billion, billion with a B, on advertising in 2020 alone. AARP and other advocates know that this is unsustainable, so we decided to do something about it at both the federal and state levels. At the state level, in 2021, AARP Virginia partnered with the Impact Project and Virginia Organizing to create Virginians for Affordable Medicine, a coalition of organizations dedicated to lowering the price of prescription drugs in Virginia. Our legislation for the 2022 session focused on the establishment of a prescription drug affordability board, which would have the authority to set upper payment limits in the state on particularly expensive drugs. A prescription drug affordability board, or PDAB, is based on the precedent of healthcare rate setting and state regulation of public utilities, where a group of appointed individuals sets limits on what buyers will pay for certain goods after reviewing relevant information. The PDAB would not be responsible for reviewing every drug released into Virginia's market. Rather, they would examine the pricing of brand name and generic drugs which exceed certain thresholds, say a price increase of 10% or $10,000 during a 12-month period, or those drugs that have an excessively high launch price. Throughout 2021, we spoke with various legislators about the issue to gain a better understanding of the state's willingness to take this on in the 2022 session. From those conversations, we decided to approach Senator Chat Peterson as patron for the legislation. He agreed, and Senator John Bell signed on as chief co-patron. Similar to Maryland, Virginia passed prescription drug price transparency legislation in 2021, and the PDAB is the logical next step in a multifaceted approach to lowering prices, providing an outlet for the information collected through the transparency effort. Both Maryland and Colorado have established PDABs, with Colorado beginning its first drug price reviews this year. As you may expect, pharma is heavily opposed to this solution as it cuts into their profit margin. However, there is an appeals process included in the legislation that would allow manufacturers an opportunity to justify their pricing practices. Many people have asked, isn't this price fixing? And the answer is no. Virginia would not be telling manufacturers what they are allowed to charge, but that does not mean that the state is willing to pay outsized prices for drugs Virginians need to survive. Another question has been, what if a manufacturer simply pulls their drug from the Virginia market if they aren't paid what they want? While the answer remains to be seen, and Colorado is the likely litmus test, even if upper payment limits are set on expensive drugs, manufacturers still stand to make a profit, just as they do in other countries where the same drugs cost a third of the price as they do in the United States. The board is created with transparency in mind, being required to meet in open session at least 4 times a year and reporting to the General Assembly twice annually in July and December. As it stands now, Senate Bill 376 did not have what we felt was solid enough support in the Senate Commerce and Labor Committee for it to pass, so it was continued to the next session in 2023 at Senator Peterson's request. Over the next several months, we aim to build awareness of this issue through grassroots advocacy efforts, such as sharing stories of individuals affected by egregiously high drug prices, and gain better support from legislators on both sides of the aisle so we can come back strong in 2023 and pass this legislation to help Virginians who are struggling with these high prices. Our second top tier priority for the 22 General Assembly was nursing home reform. For 2 decades, the Virginia General Assembly has been asked to establish minimum staffing standards in Virginia's nursing homes, but no action has been taken. The pandemic only exacerbated longstanding issues in Virginia's nursing homes related to a lack of staffing and care standards. And Virginia is one of only 18 states with no established staffing minimums. I won't go into too much more detail as we do have Delegate Watts with us, and she has been a tireless advocate for this issue all these years. I will share that AARP Virginia has begun building a coalition in partnership with the Virginia Poverty Law Center and the State Long-Term Care Ombudsman Program, now, which is the coalition is known as the Coalition for Nursing Home Reform in Virginia. And it brings together organizations and individuals who are passionate about the need to make our nursing homes safer. So far, we have worked with the Joint Commission on Healthcare, Delegate Watts and Delegate Carr, and Senator Barker and Senator Kiggins to find some path to reform, but that fight is ongoing. Legislation introduced in the House, House Bills 330 and 646, were continued to the 2023 session with promises from members of the House Health, Welfare, and Institutions Committee to bring stakeholders together over the next several months to find a suitable solution to the staffing shortages that plague our nursing homes. Senate Bill 406, which was the same issue, was defeated in Senate Education and Health, with the nursing home industry fighting really hard to keep these standards at bay. So we're very glad that Delegate Watts is here today to talk about this issue. So I'll touch on a couple of other things and then pass it over to her. As I mentioned previously, we worked on a family caregiver income tax credit and nurse practitioner scope of practice. Back in 2020, AARP Virginia worked with Delegate Sam Rasool to introduce legislation which would create an income tax credit for family caregivers. In Virginia, family caregivers provide a total of 870 million hours of unpaid care, which is valued at about $11.2 billion annually. They are the backbone of our caregiving workforce, but they rarely see any incentive for their efforts. Out-of-pocket expenses take a toll as well, with family caregivers spending an average of $7,000 per year to ensure that their loved ones have what they need. The bill unfortunately failed in the House in 2020. But fast forward to 2022, and Delegate Rasool brought the legislation back with House Bill 291, this time with the full support of the Joint Commission on Healthcare. The Virginia Family Caregiver Income Tax Credit would be a non-refundable credit of 50% of qualifying expenses up to $1,000 annually. Covered expenses are things like adult daycare, respite care, transportation, home modifications, equipment and assistive technology, and home health aides. Day-to-day living costs such as food and clothing would not qualify. Individuals with incomes up to $100,000 a year and couples with incomes up to $200,000 combined per year would be eligible to apply for the credit. And while $1,000 may not sound like much, it can go a long way to make caregivers feel valued as they take on these responsibilities that are emotionally, physically, and financially challenging. Unfortunately, the bill was amended to be a tax deduction, and it ultimately did not make it out of House Appropriations Committee this session. And finally, in 2021, the General Assembly passed legislation introduced by Delegate Dawn Adams to allow nurse practitioners to apply for autonomous licensure following 2 years of clinical practice as part of a physician-supervised care team. That bill passed and went into effect July 1st, 2021, but only with the addition of a sunset clause of July 1st, 2022, meaning that this year the state would revert back to the current requirement of 5 years of physician-supervised practice. So in this 2022 session, Delegate Adams came back with another bill, House Bill 1245, which would repeal that sunset clause and make the change a permanent part of state code. It passed easily in the House. However, there was enough opposition in the Senate Health Professions Subcommittee to prevent it from moving forward very easily. A substitute bill was created that allows the nurse practitioners who applied for autonomous licensure between July 1st, 2021 and June 30th of this year to continue to practice independently, but it keeps that sunset and it moves Virginia back to the 5-year requirement. AARP Virginia strongly supported the repeal of the sunset clause, as nurse practitioners are highly educated, qualified clinicians who should be allowed to practice to the full extent of their education and training as they are in other states. This increases consumer access to healthcare, particularly in rural and other medically underserved areas of the state, and it reduces unnecessary healthcare costs. As you can tell, many of the issues we advocate for take multiple years to see any success, for we're always up for the challenge. If you have any questions about our work in the General Assembly, please get in touch. And if you're interested in being an advocacy volunteer, we would love to hear from you. And of course, if you or your family or friends have any stories to share about how any of these issues are affecting you, we'd love to work with you to share those stories with legislators who are making these important, sometimes life or death decisions in our General Assembly. So I thank you for your time and attention. And now I will turn it over to the Honorable Delegate Vivian Watts. Delegate
Thank
Watts.
thank you so much, Natalie. So I'm going to jump right in because I'm sitting here thinking I could go on and on and on this. So let me just start with the fact that Dave and I have long-term care insurance. Somehow, despite COVID, we're both still healthy. We can support each other. So we are the model of aging in place, as I think many, many people in your audience are the model of aging in place. And that has been Virginia's focus for a long time, is to support all kinds of services to allow you to age in place. Yay, good, fine. But obviously, there comes a time when many people can no longer age in place. So if you've got long-term care insurance, you're going to go in on a private pay. And if your assets have held out, you'll be pretty well taken care of in many of our nursing homes. But then think of how long we worked to try to get expansion of the Affordable Care Act, so that those who could not afford insurance had coverage. And that's what we're talking about with the serious problem of lack of staffing standards in nursing homes. Because with all of the emphasis on aging in place, the parallel to that has been to be admitted into a nursing home on Medicaid. The standards are extremely high. I would argue one of the highest in the nation, so that you cannot get admitted on Medicaid unless you cannot perform at least 2 of the functions of daily living: feeding yourself, being able to get up and go to the bathroom, being perhaps the most critical. So with that being the population of, give or take, at least half of our residents of nursing homes, the staffing is all the more critical than if they were more fully functioning. And yet, again, we have one of the highest standards of getting in as far as acuity and need, and yet no standards as far as level of care. Now, we start out by saying, thank you so much. I'm so glad to see you. So believe me, when I say I'm so glad to see you, it is from the depth of my being, because again, let me emphasize, 20 years, 2002, I introduced the first bill on nursing home staffing standards. And virtually every year, unless there was a severe bill limit, I put it in again and again and again and again. And most of the time, it was pretty lonely. It's only really been since COVID, and I would underscore, being a numbers person at heart, as I have run these numbers, not just at the beginning of COVID, when it hit some of Virginia nursing homes particularly hard, but on through the months of the pandemic. Virginia has 30% higher proportion of our COVID deaths occurred in nursing homes than the average state. And I would underscore that really brings on home the serious problem that has existed because we don't have adequate staffing. Before I go on that point, let me underscore, having said all that, again, how does that affect most of us who are going to go in as private care? Because many nursing homes, I'm not going to use the word all, have some Medicaid population. Other nursing homes, when you look at the average of at least half of our population is on Medicaid, have substantial numbers of their populations on Medicaid. So that if you're underfunding the staffing, because the amount that the state pays and the amount then that we draw on a match from the federal government is at a much lower level, because we are not recognizing the acuity of our Medicaid patients because of the way in which we have tried to say, well, let's just keep them out of nursing homes. Wonderful, But with that comes the obligation, if they're in nursing homes, then we've got to fund a staffing level that is recognizes the acuity of need. So if the nursing home is not getting what they should be getting for these particularly acute patients that are there on Medicaid, it's going to affect the entire population of that nursing home, either all of the above, level of care, cost of care, all of the critical elements of what a human being should expect there as they are needing the care of the nursing home. So why has it been all this time? Well, it's cost. It is absolute cost, as well as the importance of the issue. So not only am I glad to see AARP and other groups that represent aging, but also extremely glad that the coalition now is broadening out to include groups like the Poverty Law Center. Because only if we recognize that the human being that we cared about in the expanding of under the Affordable Care Act is the same human being who is laying in the nursing home, no difference, will we act on this as we should? And it has to be a total population. When I first got into this, as many in your audience, were concerned about some folks that I knew, my sister in particular, at this level of care in another state and on Medicaid in rural Illinois. Became that much more aware, but also had some very effective constituents. But one of the problems in the need that we have to get understanding of these issues, that quite frankly, many people, when their loved one has died, they close that chapter in their book. They don't go on to make sure that that experience is heard in public policy. But also, quite frankly, oftentimes you are the contemporary of the person who has died. So it's one of those things that once you get into it with a loved one, your carry through on it, unfortunately, is not as long as other issues such as well, public education. Obviously, you're starting at a young age and it's a lifetime involvement. So that becomes one of the problems of why it has languished and languished and languished, is because there's not the breadth of support for it that it deserves. But also back to the word cost. When I first got into it, it was, oh, well, most nursing homes do this anyway. And I never got a good fiscal impact statement until about the third or fourth year. And then they came up with about $25 million at that time, matched by federal funds. And my reaction was, good, you're finally taking it serious. This underscores the level of need at a minimal level. Fast forward, and again, year after year after year, I had all kinds of iterations on the bills to phase it in, how it would be administered, and so on. Many of those things stay very much alive in what is now the Health Commission's bill that I carried this year, as far as particularly the administration of it and how you would count the staffing levels. But with that, having the Health Commission behind it, very, very important, recognizing that this is the entire continuum of health that we have responsibility for. With that, though, the fiscal impact statement this year came back on the what should be the recommended level, which I always phased into, of 4.1 hours of direct care per 24 hours. And again, picture the individual and the level of need that they have. And the documentation on the CMS study of this is only at that level do you stop health deterioration. It's not necessarily able to bring someone into a therapeutic situation where they're improving, but at very least, and I always brought up the if you remember the Christopher Reeves who played Superman, he died as the result of bed sores with the best possible level of care. So the humanity of a basic level of care of 4.1 is to me not arguable. But the cost of 4.1 versus 2.5, which was one of my lowest levels that I've put in over this year, is coming in at $80 million, give or take $100 million of state funds to be matched by the federal funds. Again, underscoring the real need that is not being met for that level of funding to bring it up. So let me just wrap and then get into any other questions with this other element of what is happening. So again, nursing homes cover a wide variety of population as far as private pay to Medicaid. So as the Health Commission came forward with their recommendation that the level of funding deal with the acuity of care required, I'm very comfortable because this is the Medicaid patient. They are going to be your most acute care people. But when the nursing home industry came back with their emphasis on, well, we've just introduced value-based purchasing, therefore let's do that for a while and it'll take care of it. No, I'm sorry. The value-based purchasing whole concept is if you go above the minimum, then you get more, and then you get more. It's all geared towards the individuals, and I'm going to use this description, who are receiving the level of care that one would expect. And whether or not you're going further as far as, let's say, physical therapy and other things to help the person with increased functionality to be able to button their own blouse or whatever it may be. But this is for the private pay. This is not dealing with the value-based purchasing, is not dealing with the population that is critical, as I hope I have laid out, for the entire level of care in our nursing homes, but most particularly for individuals, again, that we've cared about prior to them being ending up in, I'm going to use my father's phrase, ending up in a nursing home, which was the last thing he ever wanted, but are there as human beings that we ought to care about and have a basic level of care. So with the emphasis of COVID, with now the attention from groups like AARP, as well as broad-based groups like Virginia, like the Property Law Center, it's got to happen. So let's make sure. I am surprised it didn't happen last year, but again, the cost is a major issue, and we certainly can talk about thoughts that I have as someone as the ranking member on the tax committee as far as how we would pay for this.
All right, thank you. Thank you, Delegate Watts. This is great. And I always enjoy listening to you speak about this because your passion is undeniable and you are so knowledgeable on it. And so we really are so glad that you're a champion for this. We do have a couple of questions. One is, it says there is confusion over quality and quantity of staffing. What is actually needed for improving the care of nursing home residents? And I think you touched on that some with the hours of care that are needed. But if
and I'll be more specific, and I know that this is in AARP's basic information as well. The 4.1, again, the Center for Medicaid Services, is broken down into 2.8 hours of the at the CNA level and 1.3 hours at registered nurse or licensed practical nurse. So the very direct care, the feeding, the making sure that someone early in the morning, not 10 a.m. in the morning, needs have been taken care of as far as toileting and so on. That is 2.8. So the bulk of it is going towards literally direct care. But having the supervision of RNs and LPNs being extremely important, given that there are many in nursing home where doctor visits are few and far between. So the level of training of an LPN or a RN is essential as far as direct contact with the patient and being able to see all the vital signs and what's happening.
Thank you. That's helpful. And then I have another question here. Thank you, Delegate Watts, for your passion. I live in your district and support your efforts, but I don't know what else I can do. I feel pretty helpless and wonder, how do we get people who don't understand they vote against their interests to vote a different way without insulting them or being divisive?
So I guess I have two answers, and they really are direct answers to the bottom line of the question, which again is cost. I think if you ask anybody, because again, over my 20-year period, the typical pattern of my bill would be that the health, welfare, and institutions in the House would pass it on and say, we like this, but we're going to send it to the money committee. And of course, you'd never see it again. So the cost issue has two aspects to it. Right now, if you've read the news at all, listened to anything, you realize there's all these claims, counterclaims. How much of a surplus do we have? What should happen with the surplus? How long going is the surplus, etc. And it runs head on. I'm going to take a minute to say, with long-standing needs, not just in nursing homes that we've just talked about, but particularly in mental health, where, and this is where we have healthcare professional problems, just like we do in getting necessary staffing for nursing homes, where in mental health, we do not have the trained staff we need, but we're absolutely not competitive in salaries. Same thing with nursing homes. We're not competitive with salaries. That's one of the reasons why the CNAs working more than one job were part of the issue of why we ended up with a high incidence of COVID and COVID deaths, because of bringing in from another setting. So all of those are part of that problem. We really haven't got back up on a pupil basis in public school funding. That's a real strong problem when it comes to law enforcement as well. Back in the day when I was Secretary of Transportation and Public Safety, state police recruits had post-high school education, usually 2 years. Now the recruits have GEDs without experience to go with it, because we're not competitive. So there's many pressures on ongoing needs as far as whether or not something is a surplus. So with that, a companion bill that I have put in repeatedly as far as nursing homes, I did not put in this year because I really didn't want to see it get into that mix and get diverted away from nursing homes. If it is to happen, it's got to happen because of its connection with meeting the needs of the aging population. And that is a bill that I do want to take 1 minute to explain, because it so often gets misinterpreted. With all of the federal tax reform for years, whether it's Reagan or Bush or Trump or however conservative or whatever, one of the elements that has stayed in the federal tax code is the estate tax. And the reason that it has stayed in the federal code, and Virginia used to have an estate tax, the reason that it has stayed in is because at the level of the federal estate tax, which is, I'm using round numbers, $25 million for a couple's estate, half of that for an individual, and it gets escalated every year, $25 million of taxable estate. At that level, at least 70% of that estate is all capital gains. as I've explained it, if Dave and I are lucky enough to, we'll still have a couple of 401ks that we haven't cashed in before we die. But every time we cash in, we're paying taxes. Whereas the level that we're talking about at the estate tax, $25 million, that value doesn't matter what you originally acquired it at, it passes on to the next generation at the current value. And the increased value is never taxed. So it's not an issue of double taxation. It's an issue of filling a major loophole of non-taxation at a high level. Virginia has about 30 estates on the average every year, and that's excluding all family businesses and farms and making sure that that kind of wealth and investment can carry on to the next generation. So there's 30 estates that would not be in that category. And that the latest estimate that I had is a good $60 million a year from those 30 estates. From reinstituting Virginia's estate tax with exactly the same parallel to the federal. So that, from the way I've looked at it, that kind of joining together of the accumulated wealth of 30 individuals to meet the needs of 30,000 individuals on Medicaid in our nursing homes is exactly what I would call, well, I guess I'm going to say social justice. It's just right. And this is why I have always kept that pairing, both because of the fact they're both dealing with aging, but most importantly, because I know we have to meet the needs for the nursing homes, or we won't achieve what we are doing, giving the competing pressures to meet other needs.
Yeah, that's that is such a confusing issue. I've listened to you explain it 2 or 3 times, and I'm still trying to wrap my head around it. But it makes sense. The more I listen to it, the more
I'm not
starting
taxing
to grasp
you.
it. Yeah,
Really,
I'm starting to like grasp how that works. So we have time for maybe 1 or 2 more questions. One question that we have is, how has the nursing home industry been so successful in blocking meaningful reform over the years?
Well, again, I'm going to say, from my experience, it's the 2 elements that I identified. There's not the broad-based support for change that we're now seeing. So they've been able to carry the day. They don't have much opposition to their position of, we can't do this. And by the way, I have never been someone who said that the nursing home industry doesn't need the additional funding that would come with this. I just want any additional funding to have accountability, the accountability of having staffing standards. And then, of course, the other thing being cost. So that's, with those 2 going for you, the nursing home industry's position has been held the day. Again, as you will see in what the Health Commission adopted, the way in which I've structured it is not burdensome. It ties into what the CMS requires. It's a quarterly average, et cetera, et cetera. So, and I know that there's also a question about, well, what happens now? Both my bill and Delegate Carr's bill were the chairman of HWI, Delegate Orrock, promises, and I have a long relationship with Delegate Orrock, that he's serious about taking a look at this. I'm going to say it's a look quite parallel to what the Health Commission did. So we've got a lot of the Health Commission's research and analysis to work with, and there will be at least 3 meetings. Everything seems to be, because Orrock is also looking at possible restructure of enforcement, all towards an October 1st deadline. So following those meetings will be extremely important. And I'm not positive about this, but I'm trying my darndest to be at the table, not just an observer of this, given how long I've worked with this and the elements that need to be pulled together.
Yeah, AARP Virginia had requested to be included in those meetings. And I know that there's the first one's coming up on April 27th. And we unfortunately are not invited to that one. There are some stakeholders invited, but we are not. So we will be, I'm assuming it will be streamed as they do all of the committee meetings during session. So we'll have some people observing, and we'll be submitting some written comments on that as well. And I encourage other folks, if you have comments, to submit to that committee. I'll include a link to that committee page in the follow-up to this, and you can submit some comments to the HWI committee as they consider these pieces of legislation. And then one last question we have time for. Nationally, there has been a loss of beds, but VDH reports we have gained. Why is Virginia doing better than most?
I don't know.
Okay.
I really don't know, because
I don't either.
our population isn't out of line with demographically with the aging population and the need. It is possible, and Virginia has an interesting situation. We've always, census after census, had one of the greatest spreads between wealth and poverty in the nation. And we've definitely have the second highest spread in cost of living in the nation, second only to California. So it's possible that the aging population in the urban areas, with all of the various variations that you see in terms of long-term care and CCRCs and so on, who have Medicaid beds, may be adding to the number of beds added, but they are added at the higher level of compensation for the nursing home industry, rather than at the basic need of what we're talking about, of the 30,000 that are in Medicaid and not bringing private pay with them.
Okay. Well, thank you so much. This has been enlightening and very insightful. And of course, again, I just want to thank you for your long time effort to get this done. I'm glad that we have started this coalition. We had a few coalition members, I think, on the line today. So they're just as passionate about this. And we're trying to grow that coalition. I know that your advice was we need a coalition that is as strong as the one that expanded Medicaid in the state. So we're talking about our strategy and figuring out, what our next steps are to make sure that we get the voices at that table that need to be there. So all of you who are here today, if you have interest in this issue and you want to get in touch, if you're interested in the coalition, or if you have friends and family who maybe work in organizations who you think need to be at this table, certainly let us know, and we'll get you on our list. But I appreciate you so much, and thanks for being with us today. And we'll keep up the fight.
Wonderful.
All right. Have a wonderful day, everyone.